A hearty good evening and welcome to the session on medical disorders associated with infertility. We are glad to have Dr. Sangeetha among us today to help us understand the topic. She will take us through that and more in this session today. Doctor, you have the stage. So sorry guys, I guess doctor is facing some internet issues. We'll be right back in 2 minutes. Please be patient and keep watching.
We're in the batch.
Okay, you can start. Hello, everyone. Am I audible? Can I start the session? Can I go ahead? Yeah. There are various medical disorders which are associated with infertility. Most common ones are thyroid dysfunction, endocrine disorders, prolactin disturbances, diabetes, hypertension, obesity, so many medical disorders. In that, the most common thing is thyroid disturbances. So that has a very important endocrine, and it is an important endocrine and immunological factor which plays a very important role in reproduction. Assisted reproductive technology has led to a tremendous change in the perspective of infertility. So today's topic, I would like to limit myself only with thyroid disorders associated with infertility. In female, thyroid hormones are involved in every phase of reproduction, right from the effect on the prolactin level when there is an onset of puberty and ovulatory cycles. It can lead on to recurrent miscarriages, it can lead to amenorrhea, it can lead to galactorrhea because of high prolactin level. And the incidence of infertility is high among women who have PCOD and who have thyroid disorders. In the male, it can be a reason for increased estrogen production, which can lead on to altered spermatogenesis. The sperm production might be at fault, which can lead on to low semen quality and low motility. So today I would like to restrict only with thyroid disorders. Thyroid hormone acts on nearly every cell in the body. It has a profound effect on estrogen and androgen metabolism, on the menstrual function, and on fertility. And it may also cause a delayed onset of puberty. It can lead on to an ovulatory cycle. An ovulatory means ovulation might not happen. When people have irregular cycles, people think of only PCOD, but even thyroid disturbance can lead on to anovulatory cycles, and miscarriage rates are little high in women with thyroid disturbance. Undiagnosed and unexplained thyroid diseases can have an adverse effect on fertility. So, what happened in 2017? The American Thyroid Association came up with a guideline which said that evaluation of the serum TSH level, thyroid stimulating hormone, is mandatory for all women who are seeking infertility care. So, normal TSH level is a prerequisite when they are planning for pregnancy. So, it is included in the preconceptional counseling. So, thyroid disturbances can be either hypothyroid or decreased secretion or hyperthyroidism. Both extremes can affect fertility. How does it affect? Hypothyroidism, what are the various types of hypothyroidism? One is overt. Overt means there is patient is having an elevated thyroid stimulating hormone and the low free T4 levels, and they are symptomatic. Thyroid hormone deficiency is obviously seen. Patients have symptoms. That is overt hypothyroidism. Next is subclinical hypothyroidism. Subclinical means there is an elevated serum TSH level, but the free T4 levels are normal. So that's only a biochemical evidence of hypothyroidism. Biochemically, that only the blood levels there is a deficiency of thyroid hormones. So, what are the clinical scenario? Most commonly, the overt hypothyroidism is seen in about 3.3 percentage of patients. I'm talking only about infertility patients who have thyroid disturbance. They are seen overt hypothyroidism. Clinical hypothyroidism is seen in about 3 to 3.5 percentage of women with fertility issues. Subclinical is the most common, where the TSH alone is elevated, free T4 is normal. It is seen in about zero point 0.5 to 40 to 43 percentage of women with fertility issues. So, subclinical hypothyroidism is the most common condition seen among women with fertility issues. Next comes the autoimmune thyroid diseases, which are seen in about 5 to 20 percentage of women with fertility issues. There is a wide range of prevalence with the variations in the TSH values. So, one third of subfertile women have thyroid disease. So, we should not ignore checking the thyroid hormones. Nearly 50 to 70% of hypothyroid patients have menstrual irregularities. As I said, they might not be ovulating regularly, so the cycles becomes irregular. They might have scanty flow. All these are features. They might be, along with the clinical features of hypothyroidism, they might have menstrual irregularities as well, and 46 percentage of women infertile patients with hypothyroidism have an associated elevation in the prolactin levels, hyperprolactinemia, which could be the cause for the galactoria. 10 percentage have inadequate corpus luteal function and a luteal phase deficiency, which can be the reason for miscarriage. So even hypothyroidism can lead on to miscarriage. So when there is a recurrent miscarriage, so it's always better to check the thyroid levels. Not only look for clinical or overt hypothyroidism, also look for anti-thyroid antibodies. Now, how frequently we see the menstrual disturbances in women with hypothyroidism? In hypothyroid women, around 77 percentage of women can have regular cycles, and only the 23% might have irregular cycles. So, how does the ovulatory disturbance happen? It probably through an impact on the ovaries and indirectly by acting on the sex hormone binding globulins and its effect on prolactin and GnRH secretion, and next even by the disturbance in the coagulation factors. There is a disturbance in GnRH pulse secretion. Because of this, there is an abnormal pulsatile release of gonadotropins from the pituitary gland. Second, because of the high TRH levels, hyperprolactinemia, prolactin levels goes high. And these are all associated with PCOD. So when there is a PCOD, women have a large ovarian volume and stromal thickening. So all these, there is a peripheral estrogen metabolism which leads on to a ovulatory disturbance. So now going to how infertility and subclinical hypothyroidism are associated. Subclinical hypothyroidism may remain either latent or asymptomatic or even undiagnosed for a long period of time. Patient will not have any symptoms. There are no RCTs. Few observational studies have said there is an association, and different subclinical hypothyroidism definitions have been used. Results have all been inconsistent. So various studies between 2002 and 2015 have said that there is no increased rate of subclinical hypothyroidism among infertile women. However, there was a slight increase in the serum TSH value of these patients. Whenever you look at the unexplained or undiagnosed infertility patient, you see a slight increase in the TSH value. So this is a subclinical hypothyroidism. Few studies said there is a higher incidence of subclinical hypothyroidism in infertile women compared to few controls. So what they found out is 84 percentage of infertile women who had subclinical hypothyroidism, when they were treated with thyroid medication, they conceived. So that means that subclinical hypothyroidism has an effect on fertility. And moreover, they found out the time to pregnancy. The infertility duration was reduced in subclinical hypothyroid patients who received L-troxin. What they found out, they did a study where patients who had subclinical hypothyroidism, one group were treated with medication, L-troxin, and the other group was not treated. So they found out the people who were given L-troxin, the time to pregnancy was shortened by few months. 9 to 10 months, most of them conceived, and people who were not taking treatment took around 2.5 years. So the duration, the time to pregnancy was reduced in women who were taking medications for subclinical hypothyroidism. So this means that subclinical hypothyroidism has an effect on ovulatory disturbance. Next, they found out that administration of L-thyroxine should be considered in subclinical hypothyroidism, women who are attempting a natural conception, with a presumption to prevent progression to more significant hypothyroidism, again once the pregnancy is achieved. Initially subclinical hypothyroidism, later it can become a overt hypothyroidism. So at least it prevents the progression, and the time to pregnancy is reduced. Further, lower dose of L-troxin therapy was required once they conceive. So, subclinically, hypothyroid women who underwent IVF had significantly lower fertilization, lower implantation, and significantly higher miscarriage rates compared to euthyroid women. All these were concluded after various studies. And subclinical hypothyroidism women who underwent IVF or ICSI should be treated with L-troxin to improve the IVF success rate. So, what major outcomes? The major outcomes are not different between the treated hypothyroidism versus control in IVF ICSI. The pregnancy rate, implantation rate, and the delivery rates were similar in both the groups. Antithyroid antibodies made no difference, nor did any overt or subclinical hypothyroidism. But IVF ICSI outcome is not hampered in women who were treated adequately with L-troxin in patients with subclinical hypothyroidism. Next, going to autoimmune diseases associated with thyroid dysfunction, thyroid and autoimmunity and subfertility. Numerous studies have been done. Pooling of the results of these studies suggests that thyroid antibodies is significantly more prevalent in women with infertility or subfertility than the controls, with an overall estimated incidence relative risk of around 2.1%. How does this thyroid antibodies affect fertility? The pathogenesis of subfertility in women with thyroid antibodies is not fully understood, but they have proposed various mechanisms which say that there might be an altered cellular and humoral immunity, there might be an associated vitamin D deficiency, or there can be a cross reactivity between the thyroid antibodies and with extrathyroid tissues, which could be the reason for the failure. These antibodies can interfere in every step towards pregnancy, right from folliculogenesis, spermatogenesis, implantation, and embryogenesis. And thyroid antibodies have been found to be associated with an women with endometriosis, PCOS, and premature ovarian failure. So, thyroid antibody testing is not routinely done, but one might consider testing for antithyroid antibodies when the repeated TSH values are even after medication it is more than 2.5 milliunits per liter, or when the patient requires a higher dosage of thyroxine replacement, or when there is a family history, then we need to do an antithyroid antibody testing. What are the treatment strategies for antithyroid antibodies? Intravenous immunoglobulin treatment with L-thyroxine is a must, and steroids are not routinely used. And IVF ICSI is done in patients who have not conceived in simple treatment (ART) to avoid a fertilization failure. There was a study where with L-thyroxine, women treated women with who had thyroid antibodies who became pregnant through ART. It was published in 2006. They found that people who were treated, the miscarriage rates were less in women who were positive for antithyroid antibodies compared to the women who were not treated. So this found that definitely there is an increased risk of miscarriage in women with antithyroid antibodies. So, controlled ovarian hyperstimulation places an additional strain on the thyroid gland. So, controlled ovarian hyperstimulation involves a rapid increase in the estradiol concentration. Hence, the impact of this controlled ovarian hyperstimulation, what we do is during IVF, we give injections to make multiple eggs grow. So, the estrogen level goes high. That becomes the impact of this high estrogen on the thyroid gland function becomes more severe. So there is a need to increase the dosage of L-thyroxine earlier and to a greater extent in these women than in the natural conception. Next goes hyperthyroidism. Till now we are speaking about thyroid deficiency. Now, how does hyperthyroidism affect fertility? The exact impact of high thyroid hormones on fertility is still not very much defined. So, some studies are limited and controlled and they are small in size. They found that the prevalence of hyperthyroidism is very low as compared to hypothyroidism. The prevalence can be between zero point 0.9 to 5.8% on a maximum range. In males, infertility might start right from the childhood when there is a hyperthyroidism. So, when there is a thyroid failure in the prepubertal period, which is associated with a testicular enlargement and alteration in the sexual hormones, and there is a macroorchidism without virilization. And longer the hypothyroidism persists, the greater the degree of damage which happens to the testicles. If adequately treated, these men can progress to a normal puberty. How does this affect? How does hypo and hyperthyroidism have an effect on male fertility? As I said, in hypothyroidism, it has an effect on spermatogenesis, it has an effect on the semen quality as well as the motility. So they say that the morphology might be on the lower side in men with hypothyroidism. Second, there can be sexual dysfunction. They might have erectile dysfunction. When there is a hyperthyroidism, again there is an effect on the motility of the sperm. How do we evaluate the serum TSH for all women who are seeking care for fertility? When there is already a history of hypothyroidism, when there is a overt hypothyroidism, they are treated with L-troxin therapy. When there is a subclinical hypothyroidism, check whether they have antithyroid antibodies. If they are negative, they don't have the autoimmune disease, then they treat only with L-troxin. If they are positive, then you have to give L-troxin therapy and follow up. Thank you. So, in the further discussions, I will discuss about other medical disorders like hypertension, diabetes, obesity that are associated with fertility. Today, I would like to restrict only with thyroid dysfunctions in fertility. So, thyroid is one basic evaluation which has been recommended for every woman or a man who is seeking for fertility issues. It's not that we should restrict to checking the thyroid levels only for female, it has to be checked for male. As I said, hyper and hypothyroidism both can have an effect on morphology as well as motility, and hypothyroidism can have an effect on the sexual function of the male as well. Thank you. Any questions? Oh, shall I end?